I will be looking at some of what we do. Like I said, I am a public health physician and field epidemiologist. Somebody asked me when I came in, so how do you work for Shell? I thought Shell is an oil and gas company. Yes, Shell is an oil and gas company. But in fact, I would say we are in Nigeria the only oil company that has a unit set out for the community. I'm the regional community health manager for sub-Saharan Africa, and our focus is mainly outside the fence, looking at the communities where we operate and having a passion for their healthcare and taking healthcare to the doorsteps of those communities. That's what we do. And I know we'll know that we have quite a large footprint in Nigeria, a lot in the Niger Delta. And if we know the terrain of the Niger Delta, we have a lot of mangrove swamps, riverine areas. So a lot of the communities, over 300 communities, many of them are in those riverine communities, those hard-to-reach areas. So I want us to start thinking of remote healthcare, telemedicine. Now, one of the things we have done to be able to reach those hard-to-reach communities is we support about 20 health facilities in about 4 states of the Niger Delta, where we've built, we've equipped, and so on. And then we also do what we call some health in motion programs, where traditionally the patient comes to see the doctor. But now, with the health in motion program, the doctor goes to see the patient. But with the recent spate of insecurity on our waterways and a few other things, some things have come up, and that's where this story for me touches base and brings a learning even to me. With some of these health facilities, we have sabbatical professors who come in to work in some of these community health facilities because we want to take healthcare to the doorsteps of the communities. But when they come in, one of the things I tell them is that these are primary or maybe secondary facilities. So we don't want you to turn this facility to a UCH or a UPTH. We want you to leave it as a primary facility when you are going. All we want is knowledge transfer to the medical officers and to the nurses that are in those communities. So when this particular professor came in, we had a round table. And I said, look, I want an innovative healthcare program for us to add to the bouquet of services that we've been giving our communities. And he said, oh, something came to my mind. In the last 2 weeks, I saw 2 seizure cases, 2 epilepsy cases. And he said, I want to start an epilepsy clinic. I said, epi what? We've had issues with HIV, and there was a lot of stigma and discrimination. A lot of those in the communities were running away because they say, oh, mama so has HIV, and they don't go to that health facility anymore. So we had just come out of that and gotten people to understand what HIV is and that it's part of hair. And then you now want to start an epilepsy clinic. So I went home, I said, we are not doing it. But that night I had a brainwave. And I said, okay, let's call it seizure clinic. What is seizure in the local language versus epilepsy? And they gave me a good name. And we said, okay, it's going to be a seizure clinic. Anyway, to cut a long story short, what happened was, in few weeks, from 2 patients, we had a blowout. We've had in about 4 months, we've had over 60 patients with different types of seizure disorders. And that's why I'm telling you this story. How did we get these seizure disorders? That means there had been a lot of people locked at home for years, gone to herbalists, gone to native doctors, gone to churches with various kinds of seizure disorders. So what happened? After about 5 or 6 patients were seen, we started getting calls from deep core communities where we discovered that in some of these communities, they could not come into town because of some of the insecurity. And they said to us that by the way, these are some pictures of when we go into the communities. Beautiful communities. We have children playing in the waters and so on and so forth. These are some of my team when we go into communities to do some of the work. That's myself there. And yeah, some of those communities we go to. So We now said, okay, you have this issue, you can't come in. Do you have smartphones? They said, yes, we have smartphones. Okay. Have you heard about WhatsApp? They said, what? Okay, do you have anybody in secondary school around you? They said there's somebody from the secondary school. Do you know about WhatsApp? He said, yes. Can you download WhatsApp where you are? He said, yes. If he goes on a tree somewhere, he can download WhatsApp. So download it. He downloaded WhatsApp. He got a video message, a video of one of the children having a seizure attack. He called us, and then he shared that video with us through WhatsApp. We opened it up, saw the seizure disorder. With the professor of pediatric neurology that was with me, we looked at it, 5-year-old, generalized seizures, some automatism, hitting his head, falling down, hitting his head, and he said, oh, this is simple and very cheap. Ernest was talking about access to care. Cheap drugs. This child had been born, he's 5 years old, he had never had a day without seizures. He has 30 seizures a day. With 200 naira, colleagues, this boy has gone down from 30 seizures a day to 1 seizure a day. He has moved from not going to school in the last 1 year or 2 years. He has started school. And this, for me, was a learning. We've talked about the highfalutin stuff about e-health. We do VC in Shell. We have them in the North Sea. We have them in offshore locations. We have the Tempus Pro. But for me, this was e-health at work. The next thing for me, a week later, we had another boy, 16-year-old Mr. TR, I call him, chronic opisthotonous position, mixed seizures, clonic, myoclonic type, maybe 500 naira in a week. His seizures have moved from 18 seizures a day to no seizure at all. We have another man who has come in, a 42-year-old. He has had seizures for 20 years of his life. He has not worked. Today, he is seizure-free. He's back in mile 3 markets. He's selling slippers. These are people who are ready to even talk about what has happened to them. What happened? Simple technology. My friends and my colleagues, I have very short time left here. For me, this has been a learning. I've heard of the stories of what Eric Topel said in his book about the creative destruction of medicine and how there's wireless technology and how it helps healthcare. But for me, this drives it home. In the last few weeks, I've seen over 30 people regain healthcare. People that have been locked up in rooms. People that have no access to care. All of a sudden, they are now living again because of WhatsApp technology. Learning. I have 3 learnings or 4 learnings. For me, I would say, don't let us think about the grandiosity. I like health meets tech, and this is what we are talking about today as colleagues. Health meets tech is beautiful and good. And thank God the Honorable Minister is here. We have the e-health policy now. But as colleagues, let's start from the easy stuff. What's the problem? What is the challenge? Let us adapt the challenge to our environment. Let us not be focused on the grandiosity of the equipment. I used to look at, we want to buy the VC machine, $20,000. We want to buy Tempus Pro, how many $1,000s? But for me, what has solved a lot of our problems now was just what's up. So let's first think of simple solutions that can take us to the promised land. Then the other big things will follow. The other thing I just remembered during these few weeks of this my learning was that I remembered medical school. And if you remember medical school, wherever you went to school, but anyway, this was for my medical school, we were not taught to think. We were taught to do what the consultant tells us to do. Am I right or am I right? Thank you. I can see one of my teachers here, Prof. Prof is taking my picture. That's what we were taught. But friends, and that's not a bad thing per se, that's apprenticeship. But I think what we should also think, what we should start doing is to think innovatively. Move to the problem-solving mode. What are the tools that are available? What is the easiest technology? Is it sustainable? Can we repair it here? Can I follow up on it? And then we will be able to take e-health. Health will really meet tech. And let me say, and I say this with all sense of responsibility, I work for Shell. And this is an organization where there are a lot of engineers. And what I have learned is that Shell has taught me to think innovatively. Oil exploration with engineers in Norway, in the North Sea, is different from oil exploration in Scotland. It's different from oil exploration in Australia. It's different from fracking in Canada. It's different from exploration in Gabon, even to Nigeria. As medical personnel, as development partners, we need to think innovatively. What the innovation in Kano will be different from Ibadan and will be different to Bayelsa. There is no one size fits all as health begins to meet tech. So we need to start thinking innovatively. What are the simple things that we can do to get to where our El Dorado is?